So please join me in welcoming Kim Mooney.
I'm always scared when you get applause before you open your mouth. Thanks for the introduction. I have been doing this a long time, which means that when I go to parties, people either run from me or they corner me and tell me about every death they've ever had that nobody ever listened to. The thing that's interesting about that actually is, and it says something about us, we're more than willing now to talk about deaths after they've happened. It's become more acceptable to talk about grief. It's not as easy to talk about them before they happen, which means it's not as easy to prepare. So just to set up how incredibly nebulous this is, and if I talk too fast, somebody please raise their hand. Anybody know what a terminal illness is? It's when you get sick in the airport. That's my only joke for the day. How many of you know exactly when you're going to die? I didn't think so. I always ask people at the beginning, how many of you are not going to die? And at least one smart aleck raises their hand, and then I make them come up and teach. This is a very complicated situation that we are living in today, much more complicated than it was 150 years ago. At the turn of the century, 1900s, people died when they were about 47. And they died of things that usually took them pretty quickly. Natural course of disease. Actually, I just found out George Washington got sick one night and died the next day. So there wasn't much of a need for advanced planning because people got a disease, it ran its course. They died of things we don't die of today. They died of pneumonia, they died in childbirth. People died at all ages, evenly, whereas now we expect that we're going to be pretty old when we die, which is a gift, except that many of us will spend the last couple of years of our lives in some kind of a disease process or a deteriorating process, which changes the nature of everything that we want to do and how we want to prepare for it. 150 years ago, there was a very simple medical system, and in some surgical cases, the death rate was 50%. Now, yay, that's not true anymore. But our medical system has grown to be very powerful and very defined. So one of the first things I want to say is that the medical providers in our country are legally obligated to do every single thing they can to save you. Save you means keep your body alive. It doesn't mean keep you buoyant and as wonderful as you may be right now. That's not a bad thing, because if you're young and you're in a car accident, I would hate to have somebody take me to the hospital and say, it looks a little like that kid who beat me up in 3rd grade. I'm not sure I'm going to do everything I can. You don't want discretion around this. But because it's set up that way, if you want to have treatments stopped, you have to have something in order that allows them legally and morally and ethically and personally to feel like they're following your wishes and they're not going to get in trouble. And that's why advance directives themselves are important, the paper versions of them. Before I forget, we're not going to work out advance directives or the most today, but there are some things on the back table, and one of them is a half-a-day workshop that we do specifically around what are advance directives, and then what we found out is that most people still don't understand how to fill them out. So we broke it down into technologies. What are they really? It's called Sticks and Stones Can Break Your Bones, but so can CPR. It's really important to understand what those medical technologies do. And then the third part is, how do you choose a medical power of attorney for yourself? Because we often think we should choose the person who loves us the most. And I'm going to talk a little bit today about why that might not be a good idea. So if you want those flyers, they're on the back table. Okay. Now, I would prefer to have this be conversational. So I'm going to say if you have a question, go ahead and raise your hand and I'll try to answer it. If it's a question that requires more than 3 paragraphs, I'll probably ask you to talk to me afterwards so we can make sure we get through all the materials. That work for everybody? So no one get offended if I say, talk to me afterward. How many of you have advance directives done? Okay. How many of you use the 5 wishes form? How many of you used California statutory for Colorado statutory forms? Yeah, and how many of you went to lawyers and had them help you? All right. What that means is that you probably have a variety of forms. They're all legal, but they all kind of ask you to look at things a little bit of a different way. They're all different in that respect. The 5 wishes is a very popular form, and part of the reason it became popular is that the first 2 wishes are actually your advance directives, but the last 3 have nothing to do with legal choices. They have to do with starting to unpack and think about this stuff. Because just as we do when well, here's the example I always give. If you are going to have a baby, and some of you may have already heard me say this in other places, you conceive. I'm not sure how. You just conceive. And then, let's see, what do you do next? Because I've never had children, so I'm sure this is what happens. You throw up for a little while, you fight with your husband, and then you get fat for about 6-7 months. And then you paint the nursery and have a shower, and then you have a baby, right? That's all there is to it, right? That's what I've heard. It's exactly the same when you're dying. I've never done it. But what I hear is that you get sick and you go into the hospital and somebody stands up for you and makes sure they don't take you off life support, and then you die. Well, the truth is, when you start to think about dying, which you should do when you're young, and in other cultures they make you do it when you're young, you should start thinking then about what your values are in life. And by the time you're 18, you should have your paperwork in place, because as a legal adult, you can make choices that your parents shouldn't have to make for you anymore. If you think about it, the 3 defining cases in this country around advance directives have been young women. Karen Ann Quinlan, Terry Schiavo. They haven't been the elderly, the frail elderly that we always think are going to need these. They've been people who didn't have things in place early. So I'm going to break these 2 things out today because the legislature also updated and changed the advance directive forms, and those are really important to know about. So let's just ask another question. Why do you think people don't get their way at the end of life? Even if you have advance directives written down, why do you think they might go awry and people don't get what they want? Yes, ma'am?
Well, it recently happened. My cousin's son was taken into the emergency in Swedish, and it was 3 in the morning. And the doctor, they stabilized him in an ambulance, and the doctor decided that until the nurses came in at 9, he would put off doing any surgery. And he died because of brain cancer. And then after he'd been certified brain dead twice, the doctor came in and told us and cried, and he said he should have opened up his right brain up there then and not waited. And so then they did a autopsy on him, even though he'd been certified brain dead twice and her insurance didn't pay for it. And they were all wondering if it was kind of butt covering, sort of, I mean, they didn't want it done, but they did it anyway.
So, real quickly, her nephew was taken into the ER at 3 o'clock in the morning. He had brain cancer. The doctor worked on him, but decided not to perform a specific operation until later, and he died in the interim. And the doctor, who was remorseful, had questions about whether he should have done it or not. Now, without even having to hear the whole story, it becomes clear how many gaps and questions and places there are in one story. And that's the reason that we do a lot of work, and I do a lot of workshops around getting people to sit down and think about advance directives. What you put on paper is really important, but that doesn't mean you're going to get your way. Yes, ma'am?
For me, if you have the advance directives in your safety deposit box, and then you are rushed to the hospital, how do the hospital doctors know what your wishes are?
Okay, if you have your advance directives in your safety deposit box. Let me stop right there. You shouldn't have your advance directives in your safety deposit box. Now, this is one of the confusions, is you heard the word living will, and people go, will? Wills go in my safety deposit box. There are 2 official advance directives in Colorado. There are actually 3, but I'm going to only talk about the 2 that you can fill out. One is called a living will, and for those of you who've already done this, this might be a refresher, but it's important when we look at the new legislation, because I'm going to show you these forms. One is called a living will, and it's your best bet right now about what kind of choices you might want. It's your best bet. If you're not very educated at all, you've watched ER and decided that you don't want to be, you only want to be resuscitated by the cute doctor. Or you think you're going to be resuscitated and you'll go home in 50 minutes. If you're very educated, your choices in your living will be based on not specific instances, because I guarantee you, you may think you're going to die of brain cancer and you may end up in another situation. If you're very educated, you will have thought about your choices based on things you absolutely know you don't want, and the rest of them will be based on your values. What is it that I want out of life? Do I want to be healthy and moving around? Do I care if I'm crippled as long as I can think? Am I okay with being alive if I can't hold my grandchildren? Those kind of values are more important than the medical situations you try to list out. Because those are the things that help you make decisions when you can't know what kind of situation you're going to be in. So one of the failures of advance directives is that we're predicting into the future what we think we might want. I have 2 things to say to that. When people say, well, you can't do that, I say, well, what do you think marriage is? You say, I'll be with somebody forever? What if you change your mind in 25 years? You have to predict. And that's why going on your values has a much better chance than listing specific things. The other thing about it is, when you start to think about your values, it helps you right now think about what you want in life. So it's a real gift. The third thing that's important is, regardless of what you write down, there's an actual term for this, and I don't remember what it is, but people say things like, oh, I never want to be kept alive if I can't hike. Guess what happens when they can't hike? I can stay around a little bit. It's if I can't eat chocolate. That's my new limit. Then they get to where they can't eat chocolate. The goal, the human body and the spirit have a great will to live. And when push comes to shove, people were willing to settle for a lot more than they wrote on that first piece of paper. So these are reasons why the living will itself is a good guideline, and it's important to have on paper. Because if Terry Schiavo had had that on paper, they would have been able to hold it up and say, she said, she said. So that's a really important thing, even though it's projecting in the future. I'm going to describe one more, and then I want you to look at the handouts that I gave you. The second important thing to have is a medical durable power of attorney. This is not a power of attorney that allows your son to sell your car. This is a medical power of attorney. And people, again, if you're uneducated, think that that's the person who can take you off life support. If you are educated, you realize that this is the person who's going to make choices for you for maybe the last 3 or 4 years of your life. Now, what a lot of people don't know is that many powers of attorney, medical powers of attorney, which appoint your healthcare agent, many of those are used and then they're not used again. A lot of times they're invoked when someone goes into surgery or goes through a long illness, and then they're done and the medical power of attorney kind of goes out of effect for a while. That person can still be your healthcare agent if something happens later. So a lot of times we think that your healthcare agent is somebody who gets appointed to take you all the way through death. And that's not true. That person can be, you can say at any point, I don't need him anymore right now. So if you're very educated, instead of just appointing someone who loves you, you're going to really stop and think, if this person is in charge of speaking for me when I can't speak for myself, and that is why that document is much more important than a living will. You need both of them to have your wishes expressed. But if you write something down on a living will, and they take you into the hospital, and you change your mind, they're not going to say, sorry, you signed off on it. As long as you can speak and you have mental competency, they're going to say whatever you want now. So your living will is critical as a projection, but if you can speak for yourself, what you say in that moment is what will rule. That's why that medical power of attorney is critical, because that's the person who has to understand what your values are if you can't speak for yourself. The other piece of that is that that person better be able, and this is the most current information we have, all the studies are now saying, what you really want is someone who is able to have those conversations with the rest of your family, with your medical provider. And that doesn't mean just saying, what do you think, doc? That means being able to intelligently know what your, not only what your values are, but what your goals are. Because it is so complicated. There are so many different medical interventions that can do so many different things. That not only do I want to know what my values are, but when I'm saying it's okay to put a tube in my stomach and feed me, I need to be thinking about what my goals are. Do I think that that's going to get me better? Or is that going to buy me time? Or is that going to keep me comfortable? So the people who are speaking for you, really, and this is brand new, the doctors are learning how to talk to us, and we're learning how to talk to the doctors without being passive. There's a lot of training going on in medical schools right now, because another great study showed that the doctors wait for the patients to bring it up, and the patients wait for the doctors. So even though we think that there's a resistance to that, some of it's just the way we've always conversed. So the medical power of attorney, it's really important that that person be educated around how to advocate for you wherever you are. And that's the key word, advocate. And that's what's great about this organization, is I think they teach you how to advocate for yourself and for other people. So in the legislature, the new document, the most, we'll talk about at the end, because that is not for everyone. But the changes that were made in the living will and the healthcare agent appointment are really important. Now, you can use whatever form you want, and none of the forms that are out there now are negated. They're all legal. But what you want to do is be very succinct and clear for many reasons. Most of us, hopefully, will not end up in an ambulance situation going to a hospital. But if you do, you have people who, again, in the ambulance, have legal obligations to do everything that they can for you unless they have a clear sign that they shouldn't. They don't want to look through documents. They don't want to read 15 pages of checked off choices, and then, this is another problem that comes up with living wills, is how do you interpret them? They can be interpreted very differently. The three reasons that choices are not honored with people who have living wills are the person who's supposed to be making those decisions, if you can't, doesn't really understand what you meant, so they interpret them wrong. The second reason, you always say this, and then I get to the third one, I go, what was the third one? The second reason is that under pressure, they may choose more what they want to have done. It's happened more than once that someone has gone into an emergency room and said, I know she said she didn't want to be on life support, but I can't let her go. Okay. And the third one is that the documents don't follow them. You may have it, and they will be in your safe deposit box, or they're in your file and nobody knew where they were. So when they revised the statutory forms, and you have this little packet, the first one is the medical power of attorney. That's the one that appoints your healthcare agent. I think, again, both of these are really important, but the reason this is the most important is that you can still make choices if you can speak. So this is the statutory form. It's a lot simpler. There are some in the back. There's also, I have an email list sign up back there, and if you did not get handouts, or if you want to know about future events, put your name down on that. Snail mail's, email's better, but if you didn't get handouts today, just write need handouts, because I think I brought 60. So the medical durable power of attorney does what it's always done. It says, if I can't speak for myself, here's who I want to speak for me. And in the workshop we actually do exercises to help people figure out who the right person is. What they would prefer is that you have a medical power of attorney and 2 backups, and that's what the first side of this page is. I want my son to do this, and if my son can't do it, I want my daughter, and if my daughter can't do it, I want my neighbor. What is ideal is that all 3 of those people work together so that nobody's on their own making decisions. Number 2 up here, when the healthcare agent's powers begin, this is really important because this has not been in the statutory form before. What this means is, I want to wait until I'm unconscious and I can't speak and I'm not mentally competent before this kicks in, or I want it to kick in right now. Now again, that person can't make choices you don't want them to make, but if you want somebody to help you when you're going through surgery, then you want them to have what we call springing or standing orders, which means they're my healthcare agent and they can make decisions when I'm unconscious in surgery. That's an important distinction, because if you don't have that checked, if you have when my physician or other qualified medical professional has determined that I'm unable to make my own choices, then that person picks up their role when you're not able to speak for yourself. And they are then on their own to make all kinds of decisions. So the bottom line on everything I'm telling you right now is the paper's really important, but the single most important thing you can do is get incredibly sophisticated about how you have these conversations. And you need to have them over and over and over. And you need to have them on a regular basis so that when something happens, if it's an emergency, everybody has at least some sense of how to be in it. Now they say, you know, that if you read something, it makes sense to you, but if you hear it auditorily, you will remember it longer, and you will remember it more when you're under stress. So under adrenaline, you want to have a lot of different ways that people are going to be thinking about what you said. My mother talked to us about dying her whole life, but it was never morbid. She would just say, I'm going on a trip, and if I die while I'm gone, here's what I want you to do. I'm sending my ashes home, and you know, we got to the point where we all talked about it, just a little bit at a time. Still, I did one of the most unskillful things, and pardon me if I repeat myself, when I first started this job, I was so excited that I went home for Thanksgiving and I took a bunch of 5 wishes and said, so nice to be with all of you, let's talk about dying. And honestly, my brother went to the bathroom and never came back. My sister had 2 glasses right away and never heard a word I said. So part of what we try to help people with is how you open up those conversations. Because what we have learned again is that you don't want people who are just going to go into your doctor and your doctor's going to give them the choices. Doctors are incredibly skilled scientific technicians. They will address that part of you with great skill. They may not address the other parts at all. Marcus Welby would have, but I can't seem to find him around anymore. So what you want is somebody who's actually going to be thinking about your goals, you know, and what you really want and how to talk to a doctor about that. So on here, there's a place where you can have instructions to your agent. It's a little redundant with your living well, but it's still good if you know there's one thing that you do not want. In one of my audiences, I had a woman who has osteoporosis and stenosis. We all know what that is, right? Regardless of what happens to her, she does not want somebody pounding on her chest. That is clear, unequivocal. She has no question about that. That's not something you have to have somebody think about. You can write that down and be 100% sure. So some choices you know you're going to make. Other choices a lot of us make because of something we've seen that didn't work on somebody else that might work on us. And that's where it gets really sophisticated. Now here's what's changed. If you look at the back page, most of the forms before, you got to choose who you wanted as your healthcare agent, but once in a while people would show up in the hospital and they'd find out that they'd been appointed somebody's healthcare agent and they didn't know it. So here on this form, you actually sign off and then they sign off. So they know that you're appointing them to help you. Still need to sit down and do a lot of work with them about what that means, but at least this way you have involved them in the process. That's really important, so that's changed. We know in Colorado that you need witnesses, you don't need to have anything notarized. I say do it anyway, because if you're traveling in other states and they get sticky, you want to have all your bases covered. Now, the reason I'm going through so much description here is because when we get to talk to them about the most, It all ties in to your advance directives. And that document is it's not an advance directive, it's a medical order, but it will rely back on these. So I just want to be really clear about what's changed in here. These documents can be filled out and used the way they are right now. But cardinal rule is anytime you fill out advance directives, you must make sure that your previous advance directives are destroyed, revoked is written across them. You should only have one form that is outstanding. Because again, you don't want your son to come in with a predated form that's different now with choices. You should have one form. So whenever I do mine, I write on the front all the people who have a copy of it. So if I change it, I go back and make sure that they're all gone. They're not all gone. All the forms are gone, not the people. The living will that's here, it's called the Advanced Directive for Medical Surgical Treatment. Again, you are projecting into the future. So you may be 18 or 22. If you're older and you're pretty sure what your body's like and you don't think your medical condition is going to change, it may be easier for you to predict some of these things. But again, there are people who have cancer and end up with a heart attack. So everything they've written down doesn't apply anymore. What's nice about this, and here's what they've changed, is that they've made it very simple. For your living will to kick in, and this is another thing people need to know, it doesn't kick in unless you have a terminal condition. So I know people who have been afraid to take them into the hospital because they're afraid somebody's going to read them while they're, passed out from surgery and enact them. They don't take effect until two medical people, two doctors in Colorado, say, yes, this is a terminal condition, and then this is invoked. Okay, that's important. So they made it very simple. I don't want life-sustaining treatment. We're not going to go through this line by line. We'll do that in a different place, a workshop. I don't want artificial nutrition and hydration, but you will see at the bottom of those, it will say, artificial nutrition and hydration shall be continued for, and then it says, state time frame or goal. So this is a new shift as we are really starting to look, not just at, I want it for 30 days. The old statutory form used to say, must have 7 days. No, 7 days, 7.5 days might be what you really want. Or on the 8th day, you're going, well, why didn't they wait a day? You can't make that kind of concrete decision. So one of the things, again, they're starting to ask you to look at now is, what are your goals? Why do you want to be kept on an artificial nutrition? Is it for comfort? Is it because you hope to get better? Those are the kind of things that you and your healthcare agent have to think together. They added persistent vegetative state. It used to be in Colorado that you could not say that you wanted to be let go if you were in a persistent vegetative state. And I had people write at the bottom, if I don't want to be like Terry Schiavo. That was as close as they could get. Now it's a choice. In a persistent vegetative state, very briefly, are there any medical people in here? Okay. The way I understand it is it's a state of permanent unconsciousness where you may have sleep and wake cycles that look like you're conscious, but you don't have any connection with the outside world. You are not aware of what's going on around you. So now you can make that choice. Because even though medical people know that may be a life-limiting condition, it was so funky that they never really put that in there before. The other thing that this new living will gives you is the chance to put in other directions and to say, and this is important, at the bottom of the page, number 3, resolution with medical power of attorney. When we start talking about the most is a medical order. If it is signed by a doctor, they have to do what you want. That's a terrific thing. I'm going to talk about that a little bit more. But when you get into those kind of documents, your healthcare agent can't override that. So if you have old directions in here with your healthcare agent, and you work on a new form that's a much more immediate, you can check off down here saying, I want my healthcare agent to have the right to override anything else I do to make a decision in the moment. You have to do that, though. Everything on the back page of that is brand new. It just says, you know what? My son's my healthcare agent, but I want you to be able to tell my daughter and my niece and my nephew and everybody what's going on. And it also has a place where you can designate if you want your organs donated. So up until now, if you decided that you wanted to withdraw a medical treatment, you had to have what that third sheet is, a CPR directive. And for you to get a CPR directive, you have to sit down with the doctor and have them describe to you. They're not actually saying you can or can't have this. The original role of a CPR directive was for you to sit down and say to a doctor, I don't think I want to be resuscitated. And the doctor will say to you, let me tell you about what would happen in your condition. So if a 29-year-old sits down with a doctor and says, I don't want to be resuscitated, the doctor's probably going to be able to talk him out of it. Because in a full resuscitation, which can be painful and can be harmful, you can break your teeth, you can, all this stuff. For somebody who's very young, they may come back 100%, the way they consider 100%. So they're very, very reluctant to give out CPR directives to people who are probably have a pretty good chance of recovery. So when you sit down with your doctor and talk to them, like the woman I talked about who had the osteoporosis, she said, I never want somebody pounding on my chest. I don't want electrical pads on my chest. And then your doctor, after describing it so that you are clear what the implications are, has to sign the state form of DNR, of CPR directive. He has to sign it. She has to sign it.
What is CPR?
CPR is cardiopulmonary resuscitation. And that is when they pound on your chest and give you oxygen to bring you back. A DNR order is an order that is signed by a physician, either in a hospital or a care facility, that only lives in that care facility. It only counts when you're in the hospital. And it says one thing. It says, don't resuscitate me. So it's very concrete. It only has one direction in it. To have that, they'll do it when you're in the facility. It doesn't travel with you. So you may have a DNR order in a hospital, but you take off and go home and it's gone. So to have a CPR directive says, I want never to be resuscitated. And when you have that directive, you can carry that around with you, or it allows you to get a necklace or a bracelet. I'm sorry, guys, I think you have to wear the bracelet. That says you have the right not to resuscitate me. So when an ambulance shows up to pick you up, you right there, they look at you and they say, she's already made a decision. And they do not try those measures, okay? What's important about a CPR directive to know is that it only takes effect if you're already dead. So really what you're saying when you're saying revive me is bring me back from the dead. Very simple. It sounds so confusing. It's very simple. Now again, if you're 19, wow, probably going to come back. If you're 85 and you've got 3 or 4 medical conditions, the work that they have to do on you may bring you back, but this is one of the things we talk about every time I teach. Language is critical. When a doctor says, we can bring you back, back may mean something very different than you mean. When a doctor says you will recover, recover may mean something very different than you mean, which is why you and your healthcare agent have to be able to sit down and say, tell me about the outcome of that treatment based on my health. Okay. So that's the DNR. The CPR. DNR is an in-house. CPR travels with you in the form of some way that they are not obligated to respond in an emergency situation to you. Okay? These are great documents to have. If you have any form of these already in place, they're still legal. These just add some things that help close some of those gaps. Okay? Any questions about that? Yeah.
Now, I wanted to ask you about the anatomical gifts. Those of us who've reached our 70s, I only have one friend who's on no meds. Are our organs and tissues worth transplanting?
Are older people who are on medications, organs and tissues worth transplanting? Absolutely. If the wisdom in our bodies would go with them, it would be even better. What you have to realize is that only 2% of what Donor Alliance in Colorado uses are organs, because organs have to be harvested at a particular time and a particular situation. But they use a lot of bone and muscle, and not muscle, ligaments and tendons and things like that. Eyes, yeah. So I put on mine, take anything that works, and who knows what they'll end up using. I have done the keynote a couple years for the Donor Alliance group where they bring 300 or 400 families of the people who have donated together with the people who receive the donations. And I'll tell you, it's amazing what little pieces have gone into so many different people. Some people have donated parts to 6 or 7 people. They have a cutoff, and I think it's something like 85 years old, only if blah blah. So you never know. And the other thing is, it's a huge gift to even say that. You know, if they pull one little piece out of you that's helpful for someone. So yeah, yes.
I've heard that the family has to pay for the organs that are harvested.
The family does not have to pay for organs that are harvested. As far as I know, there's no charge at all, and they pick that up. Okay, so that's, yes, ma'am.
Yeah, 2 questions. When we get more forms of the 5 wishes, I have my own, but I'd like to distribute them to my kids.
You can call my hospice.
Okay, and the other question, or statement, is the medicine of palliative treatment is in the forefront now for people who are not going to get better, but how they will live with their condition.
Okay, I'll talk about palliative care in a minute. The first question she asked, though, is can she get more copies of the 5 wishes? You can. Let me give you the number for my hospice, because I didn't put it on any of the papers. And it's in some of the brochures in the back. 303-449-7740. Hospice care of Boulder and Broomfield County. If you just call them and say you want some copies of the 5 wishes, we have them and we give them out. The second question she asked, which I'll talk about later, is about how palliative care differs from hospice care.
I'd just like to ask you, my husband died in California. That same night, I had said they could harvest whatever. Someone called me and got me on the phone for about an hour and a half, asking me, I think they were looking for HIV or anything, has he ever been to England? Has he ever meet in England? I think that was mad cow disease.
Yeah.
It was interesting when I thought about it afterward, but they had to do it immediately. And then for 2 years after, the San Diego chapter of, I forgot the name exactly, sent me very nice letters thanking me. It seems they took he was 77, his veins, skin, bones, and I think his eyes. So as you were right, he died from a massive heart attack, so I don't know about his organs, but they were really very supportive of me. You know, they wanted me to come back to California and everything. But I thought the calling me, I had no idea, so maybe people should be aware that they might get I don't know what they do in Colorado.
Well, I think, okay, so what she's saying is her husband died of a massive heart attack, and she did donate his whole body, and they took veins and skin and all kinds of things you wouldn't think. She had a really positive experience with him. They called her and did an extensive interview about his history,
Yeah.
and then they followed up with her. They are very compassionate people, and they're very grateful for the gift. So, great. Thank you for sharing that. Yeah.
Kim, would you go back to the medical durable power of attorney, number 2, when agent's powers begin? You mentioned the choice between the immediate upon my signature and the other. What was the pro for initialing the immediately upon my signature?
She's talking about the medical power of attorney again, Roman numeral 2, when the agent's powers begin. Most of the time, if you just, in the older forms, it doesn't give you this choice directly. And so what that means is your power of attorney doesn't kick in until you can't speak for yourself. Okay? So again, you may come out of that. It may be something where they're in charge of your life until you die. But it used to be that was all that was listed, was when I can't speak, power kicks in. Now there are people, and this should have always been true. That's why some of this stuff isn't new law, but we're clarifying the forms. I want them to kick in now. I'm going into surgery. I know there'll be times when I'll be groggy. I know that the medical situation might be more than I can understand during this time. I want them to kick in now. So a fair number of them are enacted for maybe 6 months or so, and then the person quits acting like that again. That's an important thing to know. Peggy?
And Kim, in my work with the elders, I myself and my husband notice this now, that I see where when your dementia starts, you don't find many who have had these discussions enough that they can keep from projecting onto the one whose values were very much like theirs, and then, oh, but I didn't forget that, oh, I don't have dementia. The denial kicks in.
Working with people who have dementia and trying to clarify their goals as they go along, and they may not be aware that they're shifting, So they're saying, oh no, I can still remember things and you can't see. This is one of the reasons, and now let me go back to palliative care, that it is critically, in my mind, important that when you are approaching end-of-life issues or life-limiting illnesses, that you are working with experts who really understand that. So, very blatantly, hospice consists of people who only know about what happens. Not only, but they're focused on what happens when a body is dying and changing. That's really important. You wouldn't go to see a nephrologist if you had heart problems. So palliative care docs and hospice docs are trained to look at the changes in a body when someone is dealing with an illness where they're not going to get better anymore. Now, it could be an illness that lasts for years, but palliative care, very simply, is focused on comfort. It's not about trying to get somebody better necessarily. It's about making sure that while they're dealing with an illness, their body's not in pain to the degree they want it that way, that their heart and their spirit and their mind and their family are all considered in how they manage treatments. So all palliative care is focused on whole person comfort. Now hospice care, which is more directly and concretely at the end of life, is all palliative care. Because all that we're doing in hospice is saying, we're not trying to fix you, but we want you to be physically and emotionally and spiritually comfortable. What do you need to do to be comfortable and to finish your life the way you want? The thing about also palliative care is that they break things out into two pieces. Pain, physical, mental, emotional, existential pain, and also symptom management. Not that the regular medical profession, Western, isn't good at that, but that's not their focus. So a lot of times people come into hospice with advanced cancer and we get them out of pain and I thought pain was part of my disease. I just thought I had to live with it. So when you're working with people at the end of their life, morphine, not a big deal. They're not going to end up on the streets, stealing stuff. And morphine, when it's used correctly, works really well, and it's critical to get people out of pain. Morphine may make you constipated. Hospice people are really good at titrating and creating cocktails to keep people comfortable. So what we would hope in this country, if I'm queen, many things will change when I'm elected queen. One of them is that there would be a very natural transition when people are at the point where they realize that they have life-limiting illnesses, and those start to change, that there would be a natural transition where while they're in the hospital, they can start to look at comfort measures. Palliative care differs from hospice care because in palliative care programs, Kaiser has one, we have one, you actually can still pursue treatment. So if you're not quite ready to give up, but you know that you're in pain and discomfort, you can be in a palliative care program where you can still get curative treatments. But it allows you to be in an environment where you can also see what it's like to take care of yourself so that when you get to the point where it doesn't work anymore, you're already familiar with a very different system of care, which is about your goals. And I cannot tell you, I did this for 15 years. We describe end-of-life care to people. We say, come into hospice and we'll do what you want. We'll follow your lead. It's your goals of care. We'll take care of your family. It sounds wonderful, doesn't it? You can't do it if you've never done it. So my mother-in-law went into hospice a couple of years ago, and the nurse came in. This was a hospice that wasn't here in town. And she sat down very unskillfully and started to describe to Pat what was going to happen when her body started dying. Now, Pat hadn't asked for it. It was a shock to her. She'd had a new diagnosis. It was not skillful. But I kept my mouth shut because I wasn't going to be the hospice worker in the family. After they left, I said to her, was that hard for you? And she said it was terrible. And I said, why didn't you say something? What do you think she said? Because she's the nurse. You cannot be in a medical system for 60, 70, 80 years, and then you come into end-of-life care where the goal is completely different, and you're supposed to become a different consumer. You gotta start the education now. You've got to learn how to ask questions that are going to get you the answers that you need now, because it's not going to change if you are confronted with a medical situation suddenly. Does that make sense to people? Really important that you learn how to do that. Okay, so, yes, ma'am.
Would you please look at the Living Will, page 1, Living Will 3, and then talk a bit about the risk about that?
Living will, page 1, Roman numeral 3. Other directions. Okay. Oh, thank you. The Roman numeral 3, that was one of the things that was a decision to put into this draft. And part of the reason for that, and we're going to talk about it with the most, is that if you have other medical directives, like the most, and this was particularly put in there because of that, so it's kind of not going to make sense until I get completely into the most. If you're sitting here with another format that doesn't match with what you put in your living will, there are times when your healthcare agent can say, I know we had that on paper, but I'm going to override that and make a decision that's important in this moment. There are other times when your healthcare agent can't do that. So for example, you sit down with your healthcare agent, you make a lot of decisions based on your terminal cancer illness, and then you go into the hospital and you have a brain aneurysm or something. All your treatment choices have been based around dying slowly of an illness, and all of a sudden you're facing something completely different. The medical choices in that moment should be different for you. But your healthcare agent has to have the right to override what you signed off originally. This is going to make a lot more sense because it's directly connected to this new document the most. Okay? Does that make sense though? You have to give the person permission to go beyond what you originally said they could do. Any one more question? We'll get more, but I want to get into this other document because this is new and very exciting. And it's also very controversial. So as Ray said, the most document is the medical order for scope of treatments. This has been enacted in 5 or 6 other states. It's been called different things, the POLST, Physician Order for Life-Sustaining Treatment. And when we started working on this in Colorado, because we're very sophisticated about this, we called it the MOST, the Medical Orders for Scope of Treatment, because when you call it Physician's Orders for Life-Sustaining Treatment, it's loaded, isn't it?
Yeah.
It's already loaded. So what we're trying to do is get back to saying life-sustaining may be one thing. We're talking about absolute choices. So this is a medical order. It differs. It's more like a very sophisticated CPR directive with an attitude. The 2 first documents we talked about, you can fill out and sign. Now, I don't advocate not going to a lawyer to do those, but I do have to tell you, you don't have to have a lawyer to fill those documents out at all. If you have a big estate and you have a lot of complicated things like a trust or whatever, it's always a good idea to sit down with the lawyer and make sure that everything is in one place. You don't want to have somebody have your financial power of attorney and somebody who have your medical power of attorney who haven't talked. Because what if your medical power of attorney, what if your healthcare agent says mom needs to be in a nursing home? And the son who has the financial power of attorney says, I don't want to spend money like that because we might need it later. So you want all the pieces of your planning to be together. But those 2 documents you can sign by yourself and have witnessed. You cannot have that done with the CPR directive, right? You have to have a doctor sign off on it. The CPR directive is the 3rd piece in there. That's the one where you ask the doctor to explain to you what resuscitation is about, and they sign that document saying she does not want to be resuscitated. You can get a bracelet or a necklace or something. One woman said she was going to have tattooed right here, press here for lawsuit. But you have to have something. Again, this wonderful medical system is moving around you, and you have to have something that says stop. Now, even though advanced directives are really cool, there are a lot of times when you're not going to get stop exactly when you want it. You're going to end up in the medical system. You're going to end up in an ER or someplace, and you want your advanced directives to be able to say to them, stop right now. Okay, so whether it's in an ambulance or in a hospital, those 2 directives will say stop. The CPR directive will stop them instantly. Yes, sir. Ma'am.
I have a DNR, do not resuscitate, but a friend of mine whose husband had a heart attack and lived and everything, she says, well, if you have a little heart attack instead of a massive heart attack, how is, I didn't know how to answer her. I just thought, I don't want to, how is that?
First of all, if you can speak at all, you're just going to say, they're not going to stop. You don't have to say anything unless you have that necklace or bracelet on. And then if you say stop, they're going to stop. But you have to remember, that the DNR directive only works if you're dead. So if you have a little heart attack, you're not dead.
Okay, so that is the answer. So unless you're laying there, they come in and they think they can bring you back, that's when it applies.
Yeah.
But if you have just whatever, a small heart attack or something, then they're still going to try bringing you back.
And you know, this is really helpful because when I first started doing this, I was very confused about this form until I said to the doctor that I work with, wait, but and when and how? And he said, you're dead. You're dead. Do you want to die twice? That's what you have to decide. And if you're 19 years old, you probably do want to die twice. You know, there is no absolute guarantee to this, and I think sometimes in this country we get so wrapped up in every single person that the truth is this is a very imperfect system. And all we're doing with all these papers first, and all we're doing with every conversation I am begging you to have over and over and over, is doing our very best to get what we want. It's never going to be perfect. There was a 90-year-old man who had told all of his family he didn't want to be resuscitated, told all of his friends, everything was in place. His housekeeper showed up, he was laying on the floor, and she called 911. Yep. So it's not perfect, but you're trying to put as many stopgaps in there as you can. So this changes everything. The medical order for scope of treatment, most of you probably can't have it. It's not designed for everybody. This is designed for very chronically ill people, terminal illness, people who are in pretty constant contact with their healthcare providers. And I've had a lot of people go, well, I want to fill this out too. But really, that's not the purpose of it. It's going to take a lot of work. We're not calling this a document, we're calling it a program. And so I'm going to ask you, when you look at these, we are asking people, even though legislatively, August, this was legally passed, we're asking people not to use them. Because I'm meeting next week with most of the residential facilities and the hospitals and the ambulance people in the county to try to get all the providers on board. The reason we're doing this is, if this is a system, the whole idea of this document is to help people who are very, very close to medical emergency get what they want now. It's based on your very current situation, which we expect is going to change fast and a lot, and it's designed to be portable. The other gift of this is that we have trouble with advanced directives following people, but the reason we're doing this meeting next week is we want this to travel with the person from wherever they live into an ambulance, into a hospital, and back again. We've never really been able to pull that off, but that's one of the big goals. Yeah, that one.
Put it on a CD.
Pardon me?
We would put all this on a CD.
On a CD?
Here, it says we're supposed to mail all these things in and get it on a CD, and then we make these cards to go in your wallet.
Well, that's a good idea to do with all your advanced directives, but the most form right now, we're asking people not to use it, and you also have to have that signed, yes. Yes, that form is a medical order. Now, one of the things we've changed, a CPR directive has to be signed by a physician. I'm not going to go into every detail here because every line in here is very complicated. But this can be signed by a physician, an advanced practice nurse, or a physician assistant, yeah. Yes, that form. But it has to be signed by a medical person, one of those people, to make it valid, because it is, again, there's a difference. Your advanced directives are your wishes. A medical order is a doctor's order. Like a DNR, it has to be honored. So they are very picky about how this gets done. Because when you go into a hospital with this, if this is signed and an ambulance picks you up and takes you into a hospital, they have absolutely no choice. This is a doctor's order. This is legally what's going to keep you in line getting what you want. It's very different than an advanced directive. So when you fill these out, it's the same thing as having a CPR directive done in terms of intention, but it's much more immediate. It's not for us. It's for the people who are really close to being sick and medically, frail. So the differences here are it has to be signed by a doctor, which means that when it goes into a hospital, they have to transfer it as a doctor's order. That's very different than your wishes, just your wishes. One of the differences on here is if you look at Section A, that's what a DNR says. A DNR says, just period, stop. Don't resuscitate me, period, stop. This is a little bit more sophisticated. This says, don't resuscitate me at all. Or it says, you could do a little bit, but I don't want you to pump my heart. Or it says, do everything. So it gives you a number of different options. Again, those might be different depending on what day it is, because we're looking at this for people who have very changing conditions pretty regularly. Now, one of the reasons we're asking people not to use it is we have to get the doctors to really think about how they're going to work this out. Because it requires that those people who are living in nursing homes who have conditions where they maybe go to the hospital every couple of weeks, that doctor has to be willing to look at this and review it with them. And as they change, the doctor have to have the time, and that's one of the things that we're looking at, is how are they going to keep these really up to date. So you make your advance directives out for the future. You make these medical orders out for an immediate situation that you're going to be in, where you're going to be dealing with the medical profession a lot. It sounds a little complicated, but really what it is it's a little bit of your advance directives. They do not replace your advance directives. A little bit of your choices in a doctor's order to hold it in place. And this will allow emergency people in the hospital and whatever to follow this as an order. So again, it's not just don't resuscitate me. It's here's what I want you to do. I want you to attempt resuscitation, but I don't want you to do these other things. So try to wake me up, but if you have to pound on my chest, stop. So it gives them a lot more options. Does that make sense to people? Because this starts getting a little bit more complicated.
So what you're saying that this will change, this one will look a little differently after that consortium meets?
No, this one will look the same as it is right now, but one of the things we're trying to do is that these will be on bright green paper. So they will be on bright green paper, and it's a certain color so that when they Xerox it, it doesn't smear, you know. They said we could use Titan green, but not Martian green. So we're still working this out. But here's another important difference. Advanced directives belong, and a CPR directive belongs to the institution that you're in. So if you're in a hospital and they fill out a DNR order, that's the order that belongs to the hospital. When it leaves the hospital, you don't take it with you. Unless you have, I don't want to get complicated, if your doctor's given you a CPR directive and you have your little necklace on and your bracelet, you can wear that. That lasts forever. But the other DNR orders belong to the institution. This document legally belongs to you. This is the patient's document. It's the patient's order, and it travels wherever you go. So what we're trying to work out from other states that have done this are, for example, if you go into a hospital, they'll put a DNR order in your chart. When you go into a hospital, this stays with you. So mostly it will go in your personal belongings. And when you leave, it will go home with you. And that's one of the things we have to get everybody trained on, is we have to make sure that the ambulances know if one of these gets originated in the hospital. If a patient comes back to a nursing home and they don't have it, we have to make sure they say, I want to call and get this back here. So we have to get everybody thinking this goes wherever the patient goes. Now, the funny part, kind of weird, is that in Oregon, I think it is, one of the states that has this, they say when you go into the hospital, put it with your dentures. I mean, literally, put it with the personal belongings that go in and are coming out. I'm talking to this with one of the hospitals, and they said, do you know how many people lose their dentures when they're in the hospital? And then we said, in a really black humory kind of way, well, you know, all those people who get intubated and their teeth get cracked, give them the dentures. It's like fair play, you know. So we're trying to work those out in the county. You know, right now your advanced directives are supposed to sit on your refrigerator, so that if you're picked up by an ambulance, they know where to get them. It hasn't really worked that way. Yes?
On the CPR directive, you said not to fill out the most form unless you're chronically ill in and out of hospitals. But a CPR directive, even if you're in good health, is a good idea.
I don't think so. She said it's a CPR directive if you're in good health, a good idea. You know, you can ask your doctor to sit down with them, but it's so absolute. And this is why I keep saying it's so complicated that you can have it on paper, but what if you go in and it really isn't appropriate, and now it's a legal document? So what happens, because the chances of you writing something on paper and it being the one thing that you have to deal with are so slim. Like I'm going to say again, the woman who said, my bones are so brittle, they crack if I put heavy clothing on. I never want to be resuscitated. That makes perfect sense. But any other situation, you don't look like you're on your last leg to me. You don't even look like you're on your second to the last leg. So the chances are, if you collapse, that there may be really good ways and reasons to bring you back and to have you be the way you've been. I would rather see that for somebody like you. I'd rather see him resuscitate you, and then in a hospital situation surrounded by experts, have your healthcare agent sit with them and say, what's going on? What are the chances that she's going to come back? Now, in real life, that's a lot harder than if you just drop over. It's a lot harder to be in the system and to try to pull yourself out, but there are an awful lot of situations where you want that to happen. Yes, ma'am?
Can your healthcare power of attorney get a CPR directive for you?
That's interesting, and I believe the answer is yes. Your healthcare agent, but see, once you're in that, this is where it gets a little tricky. Once you're in that situation, yeah, I guess you could, yeah. Your healthcare agent has the power to make all the decisions you would make. Your healthcare agent, now here's another thing you need to know in Colorado. We're a weird state because we thought we were all independent and everything. In most states, if you can't speak for yourself, there's a hierarchy. You go to your wife, then you go to your oldest kid, and then that's not true in Colorado. If you can't speak for yourself, and you don't have a healthcare agent appointed, they do with this strange thing they call gathering of interested persons, and they bring everybody who may be interested in your health into the same room. Could be the uncle that you hate, the priest you haven't seen in 30 years, your sister who's just been waiting for you to die to get that dresser. They put them all in a room, and they decide who will be your proxy decision maker. So you see how fast it goes out of your hands. Now hopefully they'll make a good decision. And hopefully what you've done is you've just been remiss in getting somebody on paper. But that's one step away from you having had that conversation and choosing somebody. If they can't come up with somebody, it goes to the courts. And they appoint a guardian. And there's been more than one case where the person has died before the guardian got appointed because our court system is the way it is. So generally speaking, your healthcare agent makes every decision for you that you would have made. If you get to be, and that may be, and the reason I'm thinking about this differently is it may be with artificial nutrition and hydration, they still have to have two physicians say, this is a good idea. So that that person isn't making a big medical decision without input from the doctors. But yeah, what you want to do is you want to sit down with your individual family, your individual situation, and put all that together and talk to your doctor about it. You're going to find that places like Kaiser might have very different, not different, but a whole different way of managing this because so many people in Kaiser don't have primary doctors that they even know. So you want to find out, when you sit down and put your papers together, you want to walk it through your medical system, your whole medical system, and find out what you're not thinking about. Yeah?
If you're going to be cremated, can you still donate anything?
If you're going to be cremated, I would say you should do it before you... Wait, no. Yeah, you can donate. Yeah, you can. Now, if you're really into things like your whole body going to medical science, that is one of the times. We were going to do that with my mom, and then we found out we would have had to pay to ship the body back. So you want to do a lot of exploration around that.
Kim, I wanted to mention this is after the fact, but she just sort of came up the Colorado Anatomical Society. Now, you're probably familiar with that program. We use that for my late husband, and I'm signed up for it, where you donate your whole body to the medical school. Mm-hmm. And then you sign up in advance so that you have to contact the Colorado Anatomical Society and fill out the forms. And their whole situation is, and maybe you know all this, but maybe other people don't, they do cremation after they have used your body for medical students and put your name up on a nice plaque for your deceased person. Then they return the ashes within 2 years. And we did that. It was very satisfactory. And then the next spring they have a nice party for everybody who's donated their relatives and have memories, and the medical students are there and the dental students thanking you. And the Colorado Anatomical Society is a wonderful situation.
So she's talking about the way that the Colorado Anatomical Society takes care of you if you do a whole body donation. And they sound like they do a really nice job. They get the ashes back to you, and they have a celebration for families. What I would suggest if you're in another state or working with another group is, again, ask a lot of questions, because in the one state that we were looking at, they made us pay to ship the body to them. Some places that you don't get the ashes back, they dispose of them on. You really want to find out what's important to you and how are they going to manage it. And it is wonderful to have those gifts for the medical students. Yes, you, sir.
Have you ever met people who didn't donate because of religious reasons?
Yes, there are many people who don't donate because of religious reasons. And what they, this is a little tricky because every major religion in the world has found ways to sanction that as a gift, but depending on what part of that religion you're in, there still may be restrictions. Like the Jewish religion, often I would say as a generality, doesn't believe in cremation, but nothing is permanent and all the ways across the board. And there was a statement that I had at one time in one of my files that described the permission given by all of the world's religions and the rationale behind being able to donate and give back. If you're in the fundamentalist as opposed to the liberal section, it may really depend on who your priest, minister, rabbi is.
What happens if you happen to die in another state? You have these papers. Let's say I visit either of my daughters who are my agents. Do other states do they have a reciprocal?
Do they honor your advance directives in other states? The big rule is they're supposed to. Colorado will honor other advance directives. It's not necessarily reciprocal. So if you're going to be someplace more than a couple months, it's a good idea to check into what their requirements are. Now, and that's why I said get it notarized. You don't need to have them notarized in Colorado. You may someplace else. So it's always a good idea to check in. And they're supposed to do it in the spirit of honoring patients' wishes. It's just, again, these gaps. It could be the way one institution interprets something. So what you want, again, is you want a very powerful, clear healthcare agent who's going to help you navigate whatever systems. And just so you know, every system you're in, there is some version of advocate for you. So if you're in a hospital and something's happening that you don't like, you raise your hand and yell, I want a patient rep right now, or I want an ethics consult right now. There is some stopgap. In nursing homes, they're the ombudsman. There is some stopgap there that will take care of personal conflicts with the organization. Yes?
Something I just recently learned or was told that my agent should have the original copy.
That is something that's changing now. Okay, most of that, the Colorado, the advance directives we just saw, that used to be absolutely true, and now we're going to be starting to honor copies, but that, again, it's one of the hugest gaps. Depending on what care facility you're in, they will do it or not. I mean, that's one of the things that's really nice about these legislative changes, and the most coming out at the same time, is that we have a chance to re-educate people. I've had people call me and say, I went to my doctor's office to get a DNR or to get a CPR directive, and they sent me back to the senior center.
Yeah.
Not a lot of doctors necessarily are really familiar with how to do a CPR directive with their patients. That's frightening. Yeah. Wait, yeah, go ahead.
Is Larimer County the same as Boulder?
Well, I think this whole state, is Larimer County the same as Boulder County? These are all Colorado state forms. So in that sense, we've got the same forms. Again, the reason you want to ask questions ahead of time and have a healthcare agent is every institution may either know, remember, or make up their own rules. And they all have to have certain, hospitals are very different than nursing care facilities. So that intersection of all of these, we see this in hospice. If we have a hospice patient in a nursing care facility, we have to really work with them, because the care facilities have guidelines around how you have to offer food and what care looks like. And they're not necessarily exactly aligned with how hospice's guidelines are. So they have to work together to create a situation where all of the staff feels comfortable and the patients are being taken care of well. Hospitals have their own sets of regulations. We have a couple more minutes. Who has the most compelling, exciting questions in the room? Go ahead.
What about online registries as a place to register your documents?
Great. There are a couple, and I don't know the names of them, that were paid online registries, but Google Health, and there's one other one where you can register your documents. You can also put them on a disk. I think we should all get chipped, have little chips under our skin. I really do. But yeah, there are several different registries. The Compassionate That sheet I didn't hand out, so I have to see it. The ones that list the registries. Do you have one? She may have pulled it off a website. Yes?
I just wanted to say that the pancreas has cells that produce insulin, and they are doing studies in Miami of using insulin from cadavers, or using the cells from cadavers, injecting them into patients with diabetes, and it is helping in producing insulin in the diabetic's body. So remember the pancreas.
She said, remember the pancreas. The last battle cry. They're working with a lot of medical experiments. Yes, ma'am, real quickly. That's.
I assume if you die in another country, all by yourself, everything's off. That's something like that. And I live too.
If you're in another country, you know what I would do is I would find out what their procedures are before you go. Because I don't know, I'm sure that's different in every country. If you have any more questions, I'll be in the back of the room. And if you want more information, either sign up on the email list or call me. Okay? I hope this has been helpful. Take care.